Basically, what I want to show you is just an easy AA distraction manipulation that has no rotation involved. All we're doing is putting our index fingers on C1 on the C1 and cradling the occiput, having the patient in hook-lying position, and pulling. Basically, if you do that, you'll distract. C2, by the weight of the bed, is just going to be there, and you're putting your emphasis on C1, and you're doing a distraction. Joints respond well to a quick movement going through them. Sometimes you don't need a cavitation, sometimes you do. But for this particular joint, what's nice about it is that when you distract the joint, it can almost reset it without needing to add that rotation, because we're always worried about that curve where the vertebral artery comes up through. So it's not, and I know traction is part of it, so your premanip hold would have traction. And remember, you don't have to bring your A game. A joint can be moved either parallel to its surface or perpendicular to this surface. So we're going to try a perpendicular manipulation or a distraction manipulation. What's nice is you go angle to the mandible, mastoid process, find C2, transverse process to C1, and bring your hands up. Just like we did with the talocurl manip, we bring our elbows in close and you gently lean back. So this is your premanipulative hold. Now, you don't want to hyperflex the neck, but you don't want to hyperextend the neck. You just want to have it in a position where you know the tectorial membrane is not activated, because otherwise you're not going to have an effective manipulation. Number one. Number two, you'll have done your stress tests and screening that we showed earlier. Number three, you explain to the patient, you know what, Mr. Jones, when I did this rotation test, I noticed you were restricted on one side. Or when we were sitting, we noticed that you were restricted on one side and it reproduced your headache. What I want to do is just decrease some pressure on that joint. So I'm going to just do this and do a quick pull up like that. It's going to be a little bit faster than that. And we're going to see if you move better afterwards. Is that okay? Okay, there we go. So it's just very quick. There might be a pop, might not be a pop. That's not what we're looking for. What we're looking for is improved motion and decreased pain afterwards. You do a premanipulative hold. So you're in this area, and you lean back. Does that feel okay? Mm-hmm. Perfect. Okay, so next time it's just going to be a little bit quicker. So you go this way, and that's it. So again, when you're here, that's it. It's just a quick manipulation through the joint. You don't want to, you have to have enough pressure so your hands don't slip, but not so much pressure where the patient feels like they're being, manhandled. So it's good to start again at that lower part, take up the soft tissue slack to get right where that needs to be. Bring your elbows in. You get your stomach close here, lean back, and then the action is like that. But it's not dramatic. You don't need a belt. You don't need to have to haul the patient up. I've seen some YouTube videos that are fascinating, because I think they're trying to manipulate the talocurl joint from up here. And I don't think it's necessary. I think if you can direct your force, the joint, if you look at it, it doesn't have to, it's a small joint. So if you can focus it, there's no reason why that shouldn't be sufficient. And then you would recheck your flexion rotation. That is moving better. And so for him, he actually moved better to the left. As a result, we would follow up with neuromuscular reeducation. So as a follow-up for neuromuscular reeducation, he had an improvement in rotation to the left. So we want to make sure with his head now in weight bearing that we capitalize on that. So we're going to do some neuromuscular reeducation. We mobilize the AA joint. So we're going to get on C2 and focus the neuromuscular reeducation there. So we have him rotate to his newfound range and say, okay, can you gently push into me? Good, and I just encourage that motion. My hand is encouraging the ipsilateral motion here and the contralateral motion here. So it's like a mobilization with movement, but a little bit more specific in getting him to bring his muscles in. I'm doing this because I'm using my body because it just makes it a little bit more efficient. You follow that up with giving the patient a towel and guiding them through a home program for mobilization with movements.